Hi everyone. You are going to get the very shortened, condensed version of GI and electrolyte disorders because I am frustrated. I have been having a lot of issues recording this. So we are just going to get to the facts of this and thanks. Here are your objectives, which you can read on your own. Main differentials between pediatric anatomy and adults. Everybody has very vascular mouth and head. Kids are more susceptible and infants more susceptible to infection because they put everything in their mouth, whether it's clean or dirty. Overall, the GI tract of infants is not fully mature until 2 years of age, so that's why they get sick more often. With the esophagus, it's not fully developed till 1 month of age. That's why they regurgitate a lot of their feedings and spit up a lot. Dysphagia, remember, is when there's edema or narrowing that occurs in the esophagus, which makes it difficult for them to swallow. The stomach, basically when they're babies, it fits the size of their body. They only can hold 10 to 20 mLs. In adults, our capacity is 2,000 to 3,000 mLs. So you can just see and imagine the size difference there. Intestines, infants are born with 250 centimeter small intestine compared to 600 mLs of an adult. So that's why it's very important when we talk about some of our intestinal disorders that we try to maintain as much intestine early on in life as possible, because if infants lose a small part of their bowel early in infancy, they have more problems with absorption and diarrhea than if it occurs in adulthood. Biliary system, the liver consists of 5% of an infant's weight, and that's why it's easier to palpate in our infants. And you should practice those assessing your liver in infants because it is easier to palpate. Main assessment pieces: get that health history of the patient, get their past history if possible, depends on the age how much history they'll have. Family history, because IBD, IBS, food allergies are all hereditary or can be. Assess when symptoms began, how it's affecting their growth, plot them out on the growth chart and look where they're falling. Are symptoms acute or chronic? Ask physical or do that physical exam. Again, key piece: progress from least to most invasive, especially when palpating, because if you touch a very tender spot, they'll probably not let you assess it again. Coloring: are they jaundiced at all? Excess bilirubin usually peaks at 3 to 5 days of life, so it is more common in our infants, and especially those that are less than 38 weeks gestation. So just because you see a child who's only a week or two old and they look yellow to you, don't think right away they're in liver failure or it's that severe. It could just be they aren't excreting their bilirubin like they should be, and their bili levels are high. Abdomen, it should be flat when you're assessing it if they're laying supine. If it's protuberant, they might have ascites, fluid retention, some gas or tumor may be going on. If their mental status is altered at all, such as they're lethargic, it could be due to an increased ammonia level, which would be an indicator of severe liver disease, or because they're severely dehydrated, or maybe a metabolic diagnosis. Often too, these kids may have an issue with attention. Hydration, when we're assessing for that, again, our little infants, we can assess their fontanelle and see if it's sunken. Other things, just like with adults, check if their mucosa is pink and moist, if they have good skin turgor or any tenting, if they're crying tears is a key indicator, because our kids do cry a lot, and if they're not crying tears, it could be an indicator that they're dehydrated. Moving on with the physical assessment piece, you should assess, again, least painful to most painful. Auscultate all 4 quadrants. If they have hyperactive, it may be because they have diarrhea or gastroenteritis. If it's hypoactive or even absent, it may be due to an obstruction. So you need to report that to a physician immediately. But make sure that you're listening for the full 5 minutes in each quadrant. And again, if it's absent, make sure you report that to a physician. When you're percussing, it should sound dull or flat, which is normal. In the right costal, margin, and bladder area also, you'll have that dull or flat sound. Palpating, you want to do it lightly first to check if there's any tenderness lesions, how their muscle tone is, if they have good turgor, and then you can palpate deeper and go lower in the lower quadrants and move up to the base of the liver. Again, if you have them inhale, you should be able to feel firm and smooth edges around the liver and assess the liver. Fluids in our kids, most of you now, because you've had clinical, are used to figuring out fluid maintenance for your children. Remember, in the first year of life, the total body water decreases to about 60% of body weight, and the total body fat increases dramatically. So there's a shift, a huge shift in that first year of life between fluid and body fat, because when they're born, they have high extracellular fluid. They're more prone to fluid and electrolyte imbalances and dehydration because of their high metabolic rate, and this may even, the normal turnover of water and electrolytes in our kids is 2 to 3 times faster than in adults due to their high metabolic rate. Approximately 50% of extracellular fluid in infants is exchanged each day. You want to remember that. And another reason they become can become dehydrated very quickly is because their kidneys are inefficient at concentrating or diluting urine, and also because children have that smaller body surface area and a larger amount of fluid. Giving fluids to our kids is the same as in adults. For acute issues, we'll put in a peripheral line. More long-term, we can put in a PICC CBL port. Intraosseous access is usually reserved for trauma patients that they need to get quick access in the field or at an accident site. But it is the fastest way to get fluid in a patient because it's rapidly absorbed into the systemic circulation. And we can even start when we're doing CPR. So just remember that piece, that it is the fastest way to get fluid into our patients. Just a review of how we figure maintenance fluids for our kids. I'm not going to go into detail with this because all of you have had to do this at clinical now and know how to figure out maintenance fluids. Again, the first 3 lines help you figure out maintenance for 24 hours. My 4-to-1 method that I shared with most of you is how to figure out fluids per hour. If you do have any questions about this, please come and see me because you may have a drug calculation on your final, and we'll need to know how to do this. As I had on the previous slide, there's some sample questions in your book on page 764. If you need more practice, here are a couple more practice questions. For a 3-kilo kid, they would need 300 mLs per day. An 18-kilo kid, they would need 1,400 mLs per day. And for a 41-kilo kid, they would need 1920 mLs per day. Some of the common nutritional disorders that we see in kids related to GI is vitamin D deficiencies because they aren't taking in enough milk, which is a great source of vitamin D. They live in areas of the country that don't get as much sun, such as us, so they have vitamin D deficiencies. We are concerned about this in our kids because it can cause rickets. So relate vitamin D with rickets. If our kids are not getting enough vitamin D, again, we can provide that in supplemental form, multivitamins or vitamin D itself, or tell the parents to give the kid more milk. Vegetarian diets with parents, the main teaching here is to make sure that they're giving their child enough proteins since they aren't taking in any meats, so that they grow appropriately. Lactose intolerant kids, again, if it's in that first year of life when they're getting formula, we switch them to a soy formula. We also give probiotics to help with that gasiness, cramping that they may have as a result of lactate or lactose intake. Some GI issues that we see with our kids are related surely to feeding difficulties. A kid that's spitting up a lot, we want to make sure that we do a thorough history with the parents to really decipher if the child has pyloric stenosis or if they just have reflux. So you want to do a good assessment there. We tell parents to keep a dietary log for 3 to 5 days, really clearly explain if the child just has food drooling out of their mouth, how much they're spitting up, or are they projectile vomiting. Babies that have colic, which a lot of times is caused by gas bubbles in the stomach, and we can give them Mylicon drops for that. Main teaching with colicky babies is to really tell the parents it's okay for you to walk away if the baby's crying. Put them in a safe place, put them in a crib with the side rails up. You need to take a break, go somewhere where you can't hear the child crying, because a child has never cried themselves to death, but they will cry if you shake them to death. So teaching with colicky babies and helping the parents by telling them to get Mylicon drops, and even I'm a strong believer that chiropractors do wonders for colicky babies. Failure to thrive is when a child's weight is lower than third percentile, so please remember that, or that they fall 20% below the ideal weight for their height. Again, failure to thrive babies, it's important to do teaching with parents that they keep a dietary log on the child so we can decipher if it's a metabolic problem, if it's a feeding problem, or if there's something else going on with the child that they just can't gain weight. So some of our GI disorders that we see in kids is related to eating disorders. Two of the main ones, obesity and anorexia. These numbers, statistics come from 2011, where they found approximately 17% of children and adolescents aged 2 to 19 years are obese, or it's 12.7 million kids. Not necessarily a surprise, since obesity is on the rise also in adults, and eating habits of adults impact eating habits of children, as we learned in development that eating habits, lifelong eating habits, are developed by 3 years of age. By age 6 years, girls especially start to express concerns about their own weight and shape, and 40 to 60% of elementary school girls ages 6 to 12 years are concerned about their weight or about becoming too fat, which is just blows my mind and is very sad. And often this concern of body image and how they look endures through life, and thus usually leads them then to anorexia, which can be broken down to 2 types of anorexia: restrictor, where they're just not taking in calories or restrict the food they're eating, or bulimia, where they binge and purge so that they don't gain weight. Anorexia, if it's diagnosed, please refer. In this area, Rogers is a great place. They can do outpatient treatment, inpatient treatment. But again, these kids need to get treatment because it can lead to death. But aside from that, without the appropriate nutrients and proteins, they also don't develop cognitively. So they often lag in IQ and smarts because their brain is not developing appropriately because they aren't getting nutrients. So education with the family and with the child themselves is so huge. Obesity too, we want to do that teaching because we want to prevent all those secondary issues like high cholesterol, high blood pressure. Type 2 diabetes is on the rise in our kids due to obesity. We really need to do teaching in both of these areas. So again, one of our main GI dysfunctions we see in our kids, that's kind of a general thing related to their fluid balance, is that vomiting and diarrhea. An average of 55% of body can be water weight for our infants, but in our newbies it can be as high as 75%. That's why even a little bit of vomiting or a little bit of diarrhea can cause dehydration. So major thing with our infants, if their fontanelles are open, check their fontanelle. If it's sunken, key sign that they're dehydrated. If they have diarrhea, which are main causes for diarrhea in our kids, besides motility disorders, is rotavirus is the #1 cause for acute diarrhea in our infants, then followed by Salmonella, E. coli, C. diff. We consider acute diarrhea anything that lasts 24 hours to 36 hours. Anything greater than a few days would be considered chronic diarrhea. When our kids do have diarrhea, we want to make sure too that we aren't doing any rectal temps on these kids, that we teach parents to put barrier creams on to prevent breakdown. If there is some breakdown, have them leave their bottom open to air to dry it out and to promote that healing. So key things to do teaching about with diarrhea. We do test the stool typically to see if it is bacterial or viral, and that if it is a bacterial infection, that we do treat them with antibiotics. The other key indicator if a child is getting dehydrated, because kids do cry a lot, is if they are crying tears. If they do not cry tears, that is a key indicator that they're dehydrated. So again, I just covered most of this assessing for signs of dehydration. Again, even the body weight, even if it's 0.5 of a pound, again, in our little kids, that could be a huge difference. So assessing weight, that fontanelle, and weighing diapers, because you can have them pee in a hat or in a urinal, skin turgor. Vital signs are changes in our kids. If they're only mildly dehydrated, their BP will be normal. If it's severe, it'll be low. Heart rate, on the other hand, if it's mild dehydration, it'll be normal. If it's severe dehydration, they'll be tachy. And again, remember, the mucous membrane should be moist and pink. And if they aren't crying tears, they're probably dehydrated. Another key thing to remember is that with fevers, especially because infants can have really high fevers, that they can become dehydrated very, very quickly. So anytime they have a fever or are sick, make sure that parents are getting in at least Pedialyte in these kids, getting fluids in them so they don't become dehydrated. So moving on to some of our less common, but common in pediatrics, acute gastrointestinal disorders. We'll start with upper GI tract and work to our lower. One of the most common congenital craniofacial anomalies in our kids is cleft lip and palate. It occurs in 1 in every 700 births. Just a little patho regarding your lip and your palate, that normally your lip does fuse at 5 to 6 weeks in utero, and your palate normally fuses in 7 to 9 weeks in utero. If either doesn't fuse, then it's referred to as a cleft lip or a cleft palate. 70% of kids actually have both a cleft lip and a cleft palate. So they can occur separately or congruently. We repair lips first and then palates. A lip is usually repaired when the kid is 2 to 3 months of age. A palate will repair first at the end of the first year, so usually as early as 9 months, but we will do it as late as 18 months. Kids that are more susceptible to a cleft lip and or palate are those that have moms that smoke during pregnancy, that maybe had some prenatal infections, maybe have advanced maternal age, maybe we're on some meds like anticonvulsants or steroids or any other meds during pregnancy. Usually a cleft lip and or palate is detected during pregnancy because we can see it on ultrasound. so they know ahead of time, and we can start to help prepare them, do teaching before they even have the baby. And we want to do teaching about feeding difficulties that the child may have, some speech difficulties, they may have increased risk for ear infections, and they may have some respiratory difficulties. A lot of times these kids will have a lot of specialties that are work with them, anywhere from plastics, oral surgeons, dentists, psychologists, otolaryngologists, nurses, social workers, speech therapy. So the parents have to be prepared that there are going to be a lot of people helping and working with this child until we get the cleft lip and palate repaired. There's a lot of visuals in this PowerPoint. Here are just some visuals showing you severity. Top left upper, mild case of a cleft lip, to lower right where it's bilateral cleft lip and it goes up into the nares, and then various severities of a cleft palate. So things we want to remember with a cleft lip and palate, or you want to really note, these kids will have surgical repair, and key things you want to remember is preventing injury to the suture line. So post-operatively, we're going to teach the parents that the child should either lay supine or side lying on the opposite side of the suture. So if they have a suture on the right side, we're going to have the kid lay on their left side. If they have a suture on their left side, lay them on the right side, because you want to prevent the child from rubbing their face on the mattress or sheet, which would open up the suture or tear up some of the stitches. Also, we want to keep that suture line nice and clean. So we want to clean it, prevent infection, so it heals properly. If there is proper healing, because the face is so vascular, a lot of times you will not even see a scar later on in life. Also, post-operatively, we want to use soft restraints, even when the patient goes home, so the child doesn't put their fingers in their mouth, which can irritate the suture lines, even if they have a palate. Prevent vigorous crying, because that strain would force all the blood to their face and possibly prohibit healing. Avoid anything in their mouth, such as we don't use suction caps or hard suction caps, no spoons, no straws, no pacifier, no plastic syringes, nothing. We aren't putting anything in there, especially with the palates, because again, we don't want anything inhibiting healing. We want to promote adequate nutrition, because with a cleft lip, they can have an issue with getting a good suck. So we want to promote doing supplemental feedings if necessary. But if a mom wants to breastfeed, we do encourage breastfeeding. And again, even if they don't take in enough from the breast alone, we'll do supplemental feedings. But breastfeeding is huge, one, for the nutrients, two, also promoting that normal parent bonding. And we really want to support, provide emotional support, because it is hard for a parent to see their child with a big hole in their face, possibly a hole in their face, when they're expecting a perfect, beautiful, healthy baby. So again, we want to promote breastfeeding, but if the child is not getting adequate nutrition, breastfeeding, this is a picture of a Haberman feeder, which we use for our cleft lip babies, and it's a Haberman feeder nipple that's on the bottle. So just a picture, and so you remember the name Haberman feeder that we use for our cleft lip babies. The other key teaching piece is that you want to tell the parents to burp the baby frequently, because if they have a cleft lip, they may have a big hole, which allows more air than normal to enter when they're eating. Thus, they're swallowing it and can be gassier. So you want to promote more burping while they're doing feedings. So moving on down from facial GI anomalies to upper GI. We'll start with pyloric stenosis or hypertrophic pyloric stenosis. It's the most common reason we have to do surgery on our babies that are less than 2 months of age. Your pylorus is a circular muscle that exists between the stomach and the upper portion of the small intestine. And what happens, this becomes swollen and creates a gastric outlet obstruction, causing forceful vomiting to projectile vomiting. So you want to note that a lot of these GI disorders I talk about, you want to know what our key findings are, either from history or physical exam, and if it involves stool, what their stool looks like, and what we do to fix it. So remember those key things. So with pyloric stenosis, key diagnostic piece is parents seeing the child is projectile vomiting, and I mean they are throwing up and it's going across the room. You also on assessment would be able to palpate for hard movable olive, note that in the right upper quadrant. And if we cannot make a clear diagnosis just on these findings, we will do an ultrasound. We could also do an upper GI, but an ultrasound is our first line of diagnostic testing because it's least invasive. If we do labs on these kids, a lot of times they're they'll be metabolically alkalos, and it's a result of dehydration. Treatment for this is surgery, and we do what's called a pylorotomy. Here is just a picture of what pyloric stenosis looks like in the top. This is what the pylorus looks like prior to surgery, where the muscle is stenosed and almost completely closed. And this is what it looks like after a pylorotomy, where they've incised the pylorus to open the pyloric outlet. So continuing to move on down, malformations of our lower GI tract that we often see in our children, hernias, gastroschisis and omphalocele, Meckel's diverticulum, intussusception, and Hirschsprung's disease. Two types of hernias that are common in our children are inguinal and umbilical hernias. Inguinal hernias, we will see a bulging mass in the lower abdominal or groin area. This will especially be evident if they are crying or straining. So a lot of times parents are even able to see this or assess it, and when you get a history from them, they'll tell you, oh, I see this little bulge in their groin when they're crying or if they're straining and trying to poop. It is more common, inguinal hernias are more common in boys than girls, and our first thing we do is teach parents how to reduce this, but if it's not reducible and if it becomes incarcerated, where there's bowel and sticking through, then we may do surgery. So it can be surgically corrected so that the child does not lose any bowel. In umbilical hernias, again, with umbilical hernias, the majority of these can be reduced. We teach parents how to reduce them. 75% of our preemies are born with umbilical hernia, so it's not very uncommon. Most of the time, umbilical hernias will close by the age of 5. If they do not, and parents choose to, we will do surgery on them, and it's usually more for cosmetic reasons, especially for those girls that want to wear a bikini or, show off their midriff. They don't want their belly button sticking out, so we'll do a closure of the umbilical hernia just for cosmetic reasons. Then moving on, gastroschisis and omphalocele. An omphalocele, remember, is intestine and other viscera, which is covered by a sac, and it herniates through the umbilical cord, so remember that. And then gastroschisis is intestine and stomach, which is protruding through the abdomen wall laterally and usually to the right of the umbilical cord. So remember, omphalocele, intestines, other viscera, through the umbilical cord, gastroschisis, intestine and stomach. on the side of the umbilical cord. Often this is diagnosed already in utero because we can see it on ultrasound. Treatment surgeons should be contacted immediately after birth because we want to do surgery right away to prevent any obstructions of the small intestine and any loss of the small intestine then. Our nursing assessment, hydration is key importance because we don't want to feed these kids at all, so we want to get a line in them as soon as they're born and maintain hydration status and check for any other congenital malformations or problems. Preoperatively, we want to make sure again the kid is getting adequate fluid. We want to keep the child NPO, and the other key piece for the nurse, especially the OB nurse, is to make sure that we are covering the defect with plastic wrap to contain that moisture in there so that the intestine or the sac does not dry out at all. So we want to make sure that we're containing moisture in that area so it does not dry out until we get that kid to surgery. Post-operatively, fluid maintenance and electrolytes is huge, and a lot of times so we can let the child's bowels heal, we will have these kids on TPN and lipids. Just another visual for you. The top picture is an omphalocele. You can see that sac is coming out of the umbilical cord, where the bottom picture is gastroschisis, where the intestine and stomach in a sac are protruding out next to the umbilical cord. Meckel's diverticulum is the most common congenital GI tract anomaly. And with Meckel's diverticulum, just think of any of your adult patients that have had diverticulitis. Extremely painful, so you can just imagine how uncomfortable these kids are, especially if it's inflamed. It is a result of incomplete fusion of the omphalomesenteric duct during embryonic development. History that we will get from parents is that the child may have been having some bloody stools, again because it's so painful. They'll be very colicky, especially if the parents are touching their belly at all. Upon assessment that you're doing, you may notice that the child is very anemic. So too, the parents may say they think their child looks really pale. Physical examination, other things you will find, they'll be distended. You may be able to palpate an abdominal mass. And while you're doing your physical assessment, you may note that they have some guarding and there's some rebound tenderness. Also too, these kids will have hypoactive bowel sounds that you'll note. If you do run labs or do any testing, usually we do an abdominal x-ray to rule out an obstruction. Key thing you want to write here, the definitive test for Meckel's diverticulum is called a Meckel scan. But we also do test their stool, again looking for color, consistency, if there's occult blood, and we want to do a blood count to see if we need to give them a transfusion, because our nursing management, key things, again giving them IV fluids because they'll be MPO, prepping them for surgery, and giving them any blood products if they are anemic. Again, I like showing you guys visuals so you can get a better idea of what is going on, and this is just a picture of what it looks like, what Meckel's diverticulum looks like, and it's really just a little outpouching there in the small intestine. Intussusception occurs when a proximal segment of the bowel telescopes into a more distal segment, and this will cause edema, vascular compromise, and ultimately partial or complete bowel obstruction. It usually happens in our kids before the age of 2, and again, this is something more common or more often seen in males than in females. History when the parents bring them in is that the child is having, again, severe abdominal pain, vomiting, diarrhea, may have some crampy abdominal pain. Again, that would be hard to differentiate in these little kids, but again, because of all the vomiting and diarrhea, they're usually very lethargic. And then the key health history piece here, again, because they said, remember stools, is they have jelly-like stools, so that's key. On your physical assessment or examination, you're going to possibly be able to palpate a sausage-shaped mass in the upper mid-abdomen. So again, another differentiating factor between these GI issues. Pyloric stenosis was olive-shaped mass, intussusception, sausage-shaped mass in the upper mid-abdomen, and that's a hallmark sign of intussusception. If we need to do any labs diagnostic testing, a lot of times we will start with an air or barium enema because we possibly could reduce the intussusception by the enema alone. So by doing an air or barium enema, we want to try that first to see if we can push that telescoped area of the intestine out and straighten out the intestine, if you will. We don't want to jump to doing surgery right away because there is a risk we could perf their bowel. So we do try an air or barium enema first. Also, these kids often are put on IV, well, they're put on IV fluids because they're MPO, but we also start antibiotics and give emotional support pre and post-op. So another visual for you here is what it looks like when we have intussusception going on in the intestine, or the telescoping of the intestine into a distal area of the intestine. So Hirschsprung's disease, or congenital aganglionic megacolon, is the absence of autonomic parasympathetic ganglion cells in the distal portion of the colon, and thus the nerves at the end of the large colon are missing. So basically, it's characterized as constipation in newborns because they can't push their poop out because there's no nerve endings there. Usually these kids will present because they're newborns, and the parents may say they've never passed their meconium, or when they did, they had to like stimulate their anus. There could be a family history of Hirschsprung, so that's a key indicator of what's going on. So upon exam, we ask about the history. Did they have a meconium stool in the hospital, because it should be within the first 24 hours. If not, did they pass it at home? Also, did they need rectal stimulation? On our examination, you're going to inspect and palpate the abdomen. When you do a rectal exam, you want to check for tone. If there's not much tone or any tone at the sphincter, again, you know that they have Hirschsprung's. When you do your rectal exam, you may note that they have a forceful expulsion of fecal matter, and it's really, really stinky. Again, it's because they are not able to evacuate that stool on their own. And that's why it's smelly, because due to the obstruction and stool sitting in the intestine a long time, it becomes very smelly when it comes out. So those are key indicators or key findings. Also, when they do have a stool, it often is ribbon-like in characteristic. So here's just a visual. You see some distended sigmoid colon, the aganglionic portion, and the rectum. These kids do need surgery because we need to remove that piece where the aganglionic portion is. So what we do is we will remove the bad part, basically, and take the good part of the sigmoid colon, connect it to the rectum, and then, but temporarily we make colostomy so we can allow the intestine to heal. Once it has healed completely, we can do a takedown or a pull through. So basically, they won't need a colostomy anymore, and the intestine can allow the stool to pass through, and this patient can poop normally. So post-op is our main nursing management here, and we want to watch for signs of enterocolitis, fever, abdominal distension, chronic diarrhea, explosive stools, rectal bleeding, straining. We want to maintain bowel rest post-operatively, give IV fluids until they're taking things orally, and give antibiotics to prevent infection. And then with the colostomy or ileostomy, we need to do teaching, how to do bag changes, and make sure that the stoma of the colostomy or ileostomy is nice and pink and moist. So some of our kids do have GI dysfunctions just related to malformations, physical malformations like rectal malformations. Basically, this can occur in two forms. There can be a complete absence of the anus, or there may just be a fistula, which is not enough of a space for the stool to pass through. Our nursing assessment, we're going to assess for appropriate anal opening, and if the child passed meconium in the first 24 hours. Obviously, if you physically look at the child and don't see an anus, you know there's an anal-rectal malformation. But sometimes, again, there's just a little slit, and or they may have that anus, but the intestine isn't completely connected, so they aren't passing stool, and that you wouldn't be able to physically or visibly see. So nursing management, because obviously these children need to have surgery done in order for them to stool normally. We, again, will have them MPO, so we need to provide MP or IV fluids. Postoperatively, again, they're going to have colostomy, at least temporarily, so we want to teach them colostomy care and what to expect, because they have numerous surgeries, what to expect when the rectal pull-through is done several months later. So again, as I mentioned, anal-rectal malformations can occur as two types. One, a complete absence of the anus, or like on the right-hand side, as I mentioned, you might just have a fistula or a space where the intestine is not connected, but there is an anus. Unfortunately, because the intestine isn't completely connected, you're still unable to pass stool. So as I mentioned with the last couple GI dysfunctions, kids, as part of the treatment, need to have a stool diversion created because they aren't able to pass stool on their own independently through their anus for some point of time. So two types of stool diversions that we will create. They're both considered ostomies. We can create an ileostomy or a colostomy. It's done during a surgical procedure in which we bring a portion of the small or large intestine to the surface of the abdomen. Again, our most common diagnoses we have to create stool diversions for is gastroschisis, bowel obstructions, and short gut. Again, more visuals for you. I like visuals. One ostomy that's located on the left in the large intestine, and then you see a picture of where we may create an ostomy in the small intestine. I'm sure you discuss ostomies in med-surg, so I'm not going to go into a lot of detail here regarding them, but this is just a picture of a child that has an ostomy. You can see the nice pink moist stoma with the bag, which is collecting the stool. Main thing we want to remember is the assessment piece, again making sure that the stoma is pink and moist so the intestine doesn't dry out, and also that bowel should not be protruding through the stoma, only the stoma itself. So note star that. So appendicitis is acute inflammation of the appendix, most common cause of an emergent abdominal surgery in our kids. Average age that we do see appendicitis occur in our kids is usually 6 to 10 years of age. The patho related to it, it's due to a closed loop obstruction of appendix. The stool accumulates and then leads to that infection. Symptoms are exactly the same as with adults. So these kids present with some abdominal pain, which localizes in the right lower quadrant. They may have had some flu-like symptoms, nausea, vomiting, um, small amount of soft stools. A lot of times, again, this is misdiagnosed because we think the child just has like the stomach flu or stomach bug. Fever starts off high typically, and then will progress and continue to get high. And then if the appendix does rupture, all of a sudden instantly the child will feel better and their fever will break. And that's because, again, now they have ascites all over their abdomen, but the infection is out of that enclosed area of the appendix. Other physical assessment findings will be the child may have problems walking or getting on the exam table because the pain is so bad in that right lower quadrant. And the spot of max tenderness, I don't know if you guys talked about this in med-surg, on that right lower quadrant spot of most tenderness is called McBurney's point. So star, star, star that. Key diagnostic test for appendicitis is a CT to visualize the appendix. We also usually draw labs to see where their WBCs are at, if they have an elevated C-reactive protein also. And again, management for this is removing the appendix. So we need to do pre and post-op teaching. So again, I like my visuals, so this is just a visual of the appendix, what it looks like prior to being inflamed. And this little girl is just showing you where McBurney's point is. Again, the key spot of intensification or tenderness, which is the right lower quadrant.